We know that the best care is truly care that is holistic in nature. And who better than our palliative care experts? Our palliative care experts are those people that are in your corner and your advocate on your team. We are delighted to introduce nurse practitioner Catherine Reed, I call you Kate, who is a palliative care nurse practitioner with Suburban Hospital at Johns Hopkins Medicine, who is going to lead us through the next session. And our friend Daniel is here, and there's Dan. And Daniel is going to help with the Q&A after Kate's presentation. We're happy you're here.
For the presentation?
I believe it is, yes.
Okay.
Do you want to?
Oh, I have a mic here, yeah.
Oh, okay, good.
Yeah. Is it, which way do you go?
Let's give us one quick moment. There we go. Oh, did I power it off? Okay. Oh, there we go.
Perfect.
I think, is that okay?
Yeah, that's fine. Yeah. Okay, great. All right, thank you all. I'm excited to be here, and hello to everyone here today and to those who are at home streaming in. Just to start, I wanted to give a little background about my journey going into the palliative medicine field. So my love for palliative medicine began when I was working as an intensive care unit nurse. So we had a palliative care team join our hospital midway through my career, and I really saw the positive impact that this team had on patients and families as they navigated very serious decisions. The palliative medicine team joined when I was about to go back to get my master's as a nurse practitioner. And after watching the work that they did, I knew if I could specialize in anything, I wanted it to be palliative medicine. And this desire led me to go into a fellowship in palliative medicine here at Washington Hospital Center in DC. And at that time, I only knew of palliative medicine within the confines of the intensive care unit, but I had no idea the breadth that it touched for both the inpatient and outpatient world to help patients with serious illness. And today I'm excited to share with you all how palliative medicine can truly help in someone's treatment journey. So to start off, I want to share a scenario, and maybe to some extent what I described can resonate with some of you. So let's imagine that you have been having back pain for several months, but assumed it was a pulled muscle or something minor, but it persisted. When you had it worked up, imaging showed concern for a mass and cancer is brought up as a possibility. Suddenly you have had a biopsy, and now you're sitting in an oncology office hearing the news of the results. You're with the doctor and you hear the words, metastatic disease. You're shocked, overwhelmed, and not sure how to process this news. On top of that, the pain you originally had has gotten worse, and now you have had a hard time breathing because the disease has already spread to the bones and lungs. During this time, treatment options are brought up, prognosis is reviewed, but it's all too much to take in. You may feel overwhelmed or even alone. Now imagine a team who partners with you alongside your oncology and primary care teams. This team can help alleviate the many symptoms you now experience and possible new symptoms that may come with the treatment. They are also here to help you and your family discuss the options with all of the different implications involved and to discuss your values to help with decision making. This team is here to help with the physical symptoms along with emotional support, providing care coordination, and help you with your future goals and preferences regarding treatment. The aim is to maximize quality of life during your treatment course, and this is palliative medicine. And today my goal is to show you how this team can support you and your family. So to start off our objectives for today, I don't know if the slides went, there we go. The objectives include, we'll talk about what is palliative care, what are the benefits of having them as a part of your team, when should you be thinking about having palliative medicine involved in your care, and how is palliative medicine different than hospice care? And I want to give credit, some of my slides come from my medical director, Dr. Wilkes, who works with me in the palliative care department at Suburban Hospital. So a brief definition would be palliative medicine is an extra layer of support for patients with a serious illness. So this is in collaboration first and foremost with the patient, and then also with any primary care provider and any specialist they might be seeing, whether that's cardiology, oncology, pulmonology. And we describe a serious illness as any disease that causes significant physical and emotional burdens on patients and families. Some examples include heart failure, dementia, cancer, Parkinson's disease, and many others. So the services that are included with palliative medicine are symptom management, psychosocial support, advanced care planning, and skilled communication to help patients and families navigate the serious illness as long as it aligns with what their goals are. So we want to talk about current treatment goals and also future goals with the advanced care planning component. And in a little bit, we'll go through each of these individually. So the team that is involved in palliative care is an interdisciplinary team. So this involves physicians, advanced practice providers, nurses, social workers. Sometimes there's additional therapies such as massage and acupuncture. And all of this varies by the different institutions. Some places have their own pharmacists and chaplains involved, and other places that might be smaller, they just collaborate with the institution's pharmacist and chaplain. But overall, what we're aiming for is a team with multiple disciplines involved to truly care for the whole person. So this can be a confusing topic about when palliative care can be involved. It has been assumed in the past that palliative medicine may only get involved late in the disease course, when actually we can be involved from the diagnosis of complex illness and onward. So this shows the diagram of diagnosis, we begin care, and we can help all the way through end of life. And we are alongside life-prolonging care. And in a couple slides, I know there's a line here with hospice, and I'll describe the differences with when hospice comes involved, but I just want to show that continuum where we truly are during the entire time of the disease process. A few examples of when we are involved, of different types of diseases. So we may be involved with a curable disease, so a cancer that has a cure. And it might have a heavy symptom burden. So for instance, head and neck cancer has lots of really complex symptoms that really impact someone's quality of life. And so we're along with the oncology team to help with symptom management to improve that quality of life. We might be alongside someone for a chronic disease that they might have for many years. So this could be heart, lung, or kidney disease. And so we might assist these patients with advanced care planning, symptom management. As the disease continues on, they might experience a lot of pulmonary symptoms, shortness of breath, things like that. And then we also help with those who might have a eventually life-limiting disease, so a progressive dementia. And with this patient population, we do a lot of support for the patients, but also the caregivers. Doing advanced care planning to talk about what their future wishes are while they can make decisions. And there might come a time where they cannot speak for themselves. And so we really want to support the caregivers in helping them with making different decisions. And we can also assist them with end-of-life care as well. So to briefly go over the difference between palliative care and hospice, because this can be very confusing. So in that previous animation, there's a line that delineates when hospice care starts. And since this is confusing for clarity, like I mentioned, palliative care helps anytime during the course of a serious illness and is provided alongside of active treatment for a disease. When hospice is involved, this service can only be provided for someone who has a prognosis of 6 months or less. And then the treatment shifts from a life-prolonging treatment to focusing on aggressive symptom treatment to promote quality of life for the end of life. And both of these teams are interdisciplinary. With hospice, it's very regulated. They must have an MD, nurses, chaplain, social work volunteers. And like I mentioned with the palliative care team, we're also interdisciplinary, but the team dynamic might look different based on the different institutions. So going back, briefly I had listed the different services, so I just want to go through them individually to expound more on how we help with improving quality of life. So to start off, palliative care focuses on providing relief from the symptoms of a serious illness, but also the stress involved with a serious illness. So with symptom management, there are a host of symptoms someone could be experiencing. Pain, nausea, fatigue, anxiety. These symptoms could come from the disease itself. It could come just from the stress surrounding having the disease or from the treatments. And so we want to seek to address these symptoms holistically. So we like to have non-pharmacologic support when we can. So things like massage, acupuncture, TENS. For instance, our team at Suburban Hospital, we have massage therapy that can come and see patients in the hospital. So we try to do multiple modalities to help patients. And then, of course, we do pharmacologic treatment, which this can be very complex, and patients might be on multiple different medications that could interact. And so when patients have multiple symptoms we're also treating at the same time, palliative medicine is trained to assist with really complex symptom burden. We also want to help with relieving the stress that goes along with this serious illness. And we want to care for the emotional and the spiritual needs of someone. And so we usually have social workers or psychologists on our team as well to assist with this. We do psychosocial assessments, so we want to see what is someone's support system like? What is their home life like? How are they able to get to and from different appointments? What extra support might they need? We also help with care coordination. People are seeing a host of different specialists, and it can be really overwhelming, and we want to help be kind of that glue that binds everyone together so that everyone is hearing all the same information. We also want to help with counseling to patients and families, just talking through all the stresses, whether it's about the disease process or it's just about everything else in life that is contributing to that stress. We want to also provide education. We do a lot of education, especially on what to expect in the future with progression of disease, what could be different potential side effects, and coordinating that with whoever the primary team is. And then providing referrals to community resources as well. And we want to bring on chaplains too for spiritual support because we want to care for the whole person and not just for the physical symptoms. And like I said, having a chaplain with the team varies by site, but we always try to coordinate with someone should this be important to a patient and family. So we've just reviewed the different ways that we try to provide symptom relief. But we also bring skilled communication when there needs to be discussions about current treatment options, prognosis, and when goals need to be addressed. So here with palliative care, what we have is time to devote when treatment decisions are difficult and nuanced. So we want these treatments to be in accordance with someone's own goals and preferences, and we also want to help with providing family meetings to discuss this all together. And like I mentioned, we really want to help with care coordination. This is a really big thing that we do because we want all the specialty teams involved. We want to bring on the primary team. We want to bring on the oncology team. And we want everyone to be hearing the same thing about what is the current medical information. And then as we hear someone's goals and values, that will help guide how we should proceed with treatment options. Coordinating care with specialists is key to make sure that we are all sitting down at the table together so that the whole picture is seen and not just one aspect of someone's health. We also help with advanced care planning when there needs to be discussions about someone's future. And so with advanced care planning, what we're trying to address is, in the future, when I decline, which medical treatment is right for me? Advanced care planning puts the choice back in the patient's hands so that if in a future time someone could not speak for themselves and their medical wishes are known. So we want this to be a thoughtful discussion that includes the healthcare team and family so that everyone knows what the person's wishes are. And in the process, a medical living will can be filled out so that these wishes are documented. Advanced care planning is a process where we first want to make sure that the medical condition with its future progression is understood. And then as a person shares their values, life goals, and preferences, that helps guide what their future medical care might be. And this discussion about advanced care planning varies from person to person, and it's also dynamic for the same person. And this could change over time as the medical situation changes. So for example, if someone fills out an advance directive when they might have a mild to moderate chronic disease, they may wish to have every medical treatment pursued, even up to more aggressive interventions such as CPR being put on life support if that was ever necessary. But if the condition changes down the road and turns into a more advanced life-threatening illness, where the chances of doing CPR or life support being successful diminish, that person might decide they do not want those interventions if they were ever necessary and would want to continue to pursue all other medical treatments available up until that point. And so that's why, since this is a dynamic conversation, what is written down at one time could change over time, and so we want to keep readdressing goals. It's not a one-time conversation, but it's continuously and ongoing depending on what's important to someone and what their current medical condition is. So there's a few resources that anyone could look up if this would be of interest if you're looking to fill out an advanced care planning document. These two are really helpful, Prepare for Your Care and 5 Wishes, and you could go to 5wishes.org. They both are advanced directive documents that really simplistically walk through this process. So anyone could really probably read it and fill it out, but we always encourage you to do it with a healthcare provider. And what these forms specifically address are who would be your medical decision maker if you could not make decisions for yourself, and it walks through different criteria that they recommend be a part of that. And during this documentation, it wants you to share what matters most in your life and how you would define what quality of life is for you. And then in light of what you share, it goes through what would be most important for your future medical care. So we want to keep everything into consideration. Just of note, Prepare for Your Care is a free resource. 5 Wishes does have a small fee if someone was interested in that. But each state also usually has their own advanced care planning document that you can look up that usually is a free resource. And so a few things, some people think I need a lawyer, I need a notary. When it comes to medical advanced directives, you do not need those things, okay? We actually recommend that you do this with a healthcare provider. So that we can talk about all the different dynamics, all the different, it'll go through all the different potential interventions and asking you what you would want. And so the healthcare provider can help talk to you about the implications with those different interventions, and especially in light of whatever the current medical condition is. And another important thing is that we really want family or whoever is closest to you to be a part of this conversation, especially whoever you want to have as your healthcare agent, because those closest to you know you the best, and they will be the ones speaking for you if for some reason you are unable to. And so this is another good resource, just if you're wondering, how do I even get this conversation started with those closest to me? And so the goal of this, it's the conversationproject.org, is to help everyone talk about their wishes for care through the end of life so those wishes can be understood and respected. And this is just a good, easy way to have different resources to help you as you navigate those discussions with those closest to you. And so all providers can incorporate primary palliative care and should be incorporating primary palliative care. So all providers are assisting with addressing your pain and symptoms, depression and anxiety, or goals of treatment. So when would a specialty palliative team become involved? So usually we become involved whenever there's more refractory symptoms. So the initial symptoms that have been treated are just not really responding to the first line. And so maybe the team wants another set of eyes to help with that. Or if there's complex psychological distress or decision making that just needs really more time devoted to this. Now, like I mentioned earlier, at any time from diagnosis onward from a serious illness, we can be involved. So we don't have to wait for these things to happen. You could always request and see if a referral can be made for a palliative provider. But this is usually when we become more involved in someone's care. So I've shared the different services that palliative care provides. And you may ask, how effective is this? Is this worth pursuing, especially since you probably already have a host of different specialists on board seeing you? So palliative care has shown to prolong life, improve quality of life, reduce stress on families, and improve communication between patients and doctors. And there are a few examples of where research has actually been done to show some of these benefits. So there was a 2010 study that involved patients with metastatic non-small cell lung cancer, and what they sought to do was to see the effects of including palliative care early after diagnosis. And the conclusion they found was that there were significant improvements in both quality of life and mood. And these patients who received early palliative care had less aggressive care at end of life, but actually had a longer survival. And the mean longer survival was 2.7 months. And there was another study that looked at in 2015. This was a multidisciplinary quality of life intervention. So it wasn't specifically a palliative care team, but it was a quality of life intervention including exercise, education, and relaxation. And what they wanted to see was, does having this quality of life intervention help with adherence for chemoradiation treatment for those with advanced GI cancer? And what the study found was there was a significant more patients who actually completed their treatment and had less hospital admissions just from this quality of life intervention being implemented. So in summary, both of these studies have shown that a focus on quality of life and having palliative care involved can prolong life, lead to less aggressive care, help a patient complete their treatment, and decrease hospital admissions. So if someone is interested in having a palliative care team involved, there's many different places where we are found. So we're found in a hospital, which is where I work. We do inpatient consults throughout the hospital, and we see patients throughout. It could be in the ED, on the medicine floor, in the intensive care unit. It doesn't matter where a patient is, we can go anywhere. They're also found in outpatient centers. Some are independent, but many are embedded in like oncology practices or like heart failure practices. And palliative care alongside usual oncology care has been recommended by the American Society of Clinical Oncology as standard of care, especially for patients with more advanced cancer. And then this can also be provided at home. So this is a growing field. So in more rural or smaller hospitals, it might be harder to find palliative care, but they're starting to go out into the communities more. And so there are many palliative care services that will do home visits or telemedicine visits, which is really important because many of our patients will get to a point where it's just really hard to leave the home and you might already be seeing multiple people and going to multiple doctor's appointments. So having someone come to you can be really important and helpful. And if you want more information to get palliative care involved, just ask your doctor, social worker, case manager. There is also this provider directory at getpalliativecare.org where you can look up where you live to see who is local in your region as well. And then who pays for this service? Most insurance plans do pay, including Medicare and Medicaid. I always recommend always run it through your insurance, but we usually haven't seen many issues with this being covered. So, and as we've seen, there's many locations where you can get palliative care, insurance can cover, and so for those who qualify, there shouldn't be, hopefully, too many obstacles in having palliative care involved. And so during this presentation, we've covered the different services that palliative care provides, the team and how it benefits patients and families, and where you can find this care for yourself. And in palliative medicine, what we aim to do is walk with you in your treatment journey to enhance quality of life through comfort, support, and through symptom relief. And I think we have a time for some questions as well.
Kate, great. That was wonderful. Thank you so much. We do have some questions from the audience. And I know you covered some of these things, but I think there's so much good information, it might be just good to focus on a few of the things that, the highlights. So one of the things is, how do I know if I need palliative care? So really, what is, for me as a patient, I remember just thinking, are my symptoms bad enough or qualify really? So how do I know that if I need palliative care?
That's a great question. So, like I mentioned, serious illness is the baseline qualifier, and anyone can reach out. Like I mentioned, most teams are doing primary palliative care, so if your symptoms feel pretty controlled, you feel pretty well supported, and it feels like a lot to have someone extra, I don't think you have to have palliative care involved, but really at any point we can be involved, and if it's a question of, maybe I could have more symptom support, maybe I could have more care coordination, or just someone else to really process this with. It never hurts to have a referral. I've honestly had some referrals where I've had one conversation like in the hospital setting just to get things started, see where they're at. And then it might be an occasional touch base, or it might be like, yeah, you have a lot going on. Let's have regular conversations. Let's have regular meetings. So it really, if you're considering it, I would just recommend having a consultation and asking for it. And just seeing what the team, how they could best support you. And it might be that they can support you more than you were even thinking about. So I recommend, anyone with a serious illness, if there's any interest at all, reach out to your teams and see if you can get a referral.
Great. And on that note, so I'm thinking, my mind goes straight to, okay, how am I going to pay for this? So I know you talked about that a little bit, but so does insurance cover the
Yes.
palliative care
Insurance
services?
does cover. It's like seeing any specialist. So, even including Medicare and Medicaid, I always just say run it through your insurance as if you were seeing any other specialist, but we haven't seen any major barriers to having insurance cover a palliative care team.
Okay, great. And then probably the most popular question right now is palliative care available after cancer treatments stop?
Yes. So palliative care is available. With the overlap with hospice, part of that, if someone stops cancer treatment, what we would probably look at is what is someone's prognosis. Because whenever the prognosis changes to less than 6 months and they are not pursuing any more cancer-directed therapies, and if there isn't any other active treatment that they are pursuing, at that time we might talk about, would this be the time to bring in hospice, just because they are a big team that comes to the home. But if there's still other treatments someone's pursuing and we're not at that point, then we can definitely continue to be involved, because we want to continue to help with that quality of life, no matter if someone's undergoing aggressive treatment or not. We're there to help through the whole time.
Another is, my oncologist seems shocked when I ask for a referral to palliative care. Do oncologists typically understand the role of palliative care?
That is a great question. I think different oncology, and not just oncology teams, but different specialty teams are still learning when we can be involved. Even at the hospital where I work at, we still have to do a lot of reinforcement and education with providers that, we're not just here for when you're saying there's no more treatment. We're here to help really maximize quality of life. And that's why the American Society of Oncology even recommends, and a lot of that recommendation was based on the study that I shared about how early palliative care has improved quality of life and even prolonging life. So every oncologist, every specialist is different. And so if you ever, hopefully you wouldn't get pushed back, but if there was any question about it, just emphasizing you're just wanting every resource to improve quality of life while you're getting treatment. That's what we're here for. And some providers are involving us really early on, because they do see that benefit and they see that we're not just here for end of life care. And so, it's a process. People are still learning about it. We are a newer specialty. And so it does vary by specialist as far as, how quickly on board they might be.
And do you really need a doctor to get palliative care? Do you need a referral or?
It might depend on the state, but usually we have not needed a direct referral. If you go to this provider directory, you should be able to reach out and ask for a palliative. And if for some reason maybe you're hesitant to go through a specialist, you could always ask your primary care provider, but you should be able to even directly reach out. I've had people do that, and we've put our own referrals to the community out. So I know that it can just vary by institution, but there should be many means for you to get palliative care involved.
Okay. Oh, and here's a really good one. So with everyone, this person doesn't live near a major facility that offers palliative care. Can I get it at home?
Mm-hmm. So there is more and more palliative care in the community, which is great, and telemedicine, which is really great. Here in this area, we have a lot of patients who might live in more rural areas, and so we do, there are different palliative care teams that we will coordinate with to go to the home or to do telemedicine, and those palliative care teams aren't tied to any institutions, and so palliative care is everywhere right now. They're with institutions, they're on their own. Some of them are tied with hospice agencies, but they're still just doing palliative care, so you don't have to worry about why they're tied to a hospice agency. So I would recommend looking at that directory, but it is growing. There are still some areas where it might be a little bit more limited, but with the advancements of telemedicine, I would imagine there would be one resource at least to get palliative medicine in your home.
Great. We've got a question from a viewer on the Zoom call. What is the difference between end-stage, terminal, and life-limiting?
That's really good. So, and I don't know if this question stems from some advanced care planning documents, but you know, a lot of advanced care planning documents talk about what are your wishes for, end stage, terminal, or like vegetative state is sometimes listed, but end stage might be just like you're at the most advanced stages of your illness. Prognosis might vary on that though, for person to person, and it's hard to say. Terminal is likely, this is a little bit fluid and it's not always very clear in the advanced directive, but terminal might be more, things are a little bit more imminently leading to end of life. But honestly, these documents are helpful, but they aren't always the most clear. And these conversations are very nuanced, so you fill them out to the best of your ability, but that's why I always recommend talk to the person who is going to make decisions on your behalf if you couldn't, and talk to a healthcare professional, and especially in the moment when things are happening, because we try to define things as best we can on paper, but that doesn't always realistically look at someone's picture currently, and so that's why this conversation is always nuanced and varying. So we just have to fill them out as best we can based on that.
Okay, thank you. Here's a popular one. Can palliative care prescribe cannabis? Medical cannabis?
So some people can. That is just based on if they're certified to do that. So there are some palliative care providers who may, but it's not like across the board. So I don't want to say yes just for everyone. It really just depends on if they're certified to do it themselves, yeah.
Okay.
But if that was like of interest, they could also probably talk to resources if that was important to someone.
Okay. This is back to an insurance question. So does insurance cover the more holistic approaches you mentioned?
Yeah, if it's like a palliative care service specifically, it should be covered by insurance because we're just like any other specialty team. And so if that holistic care, quality of life care is through a palliative care team, since it's a medical provider, it should be covered by insurance, yeah.
Okay. Oh, and here's a good one. So when is it best to complete advanced directives? It seems negative to bring it up to my loved one. Who assists with this?
I say as soon as possible. Even if, you could have really nothing going on, but maybe you've just had different experiences. And like I mentioned earlier, the conversation will vary. So if right now you have either no disease or just mild to moderate disease, we just want to know right now what your wishes would be. But we would want to then talk about if things got worse, if this did become an end stage process, or we're looking at more imminent end of life, then at that time, what would you want? So I say as soon as possible because you just frankly don't know. We don't know the future and we don't know when things could change. And so it's just really helpful to know what your wishes could be. And I think also just defining for you and sharing with your loved ones, what is quality of life for me? Because that's subjective, that's different for every person. And so knowing your values beforehand, not just would I want this or that treatment, but what are my general values? What's important to me? I'm a very active person. I want to be able to be up and walking and doing X, Y, or Z. And if this treatment would not bring me back to that, then I would not want it. That's kind of more of the conversation that needs to be had. And it's so helpful if something did happen, where we would then be relying on whoever you would want to be making those decisions. And so while it might feel kind of negative, it really is actually helpful because if they're gonna be the ones making that decision for you, if they've had no conversations, let me tell you, it's already gonna be overwhelming and daunting. But if they've had that, it really can help then guide the healthcare team to give recommendations to that person to help make decisions for you.
Okay. Here's a tough one. So my oncologist has told me it's not time for palliative care. It's confusing. So any suggestions on how to handle that?
Yes. So, if someone mentions it's not time, I might, well, number one, there's other avenues you use to, get a consult, to get a referral to us, if you're really having a barrier with a certain specialist. But if you're comfortable in the conversation, like I mentioned, it's a growing field. Even our specialists are still learning about how early we can be involved. So maybe even asking, like, what do you mean it's not? Like, what are your thoughts? Because if they're thinking this is only when we're not doing treatment that you have palliative care, then really bringing up, like, I just want to improve my quality of life. Like, and it's not saying that that specialist is doing a bad job. It's just complicated. And so you just want that extra support system. Like, I just want extra support. I just want to improve my quality of life. And that shouldn't, I'd hope, have any pushback. But, like I mentioned, going to finding the provider and reaching out to one yourself, or even, talking to your primary care provider would be another avenue too.
Okay, got several more here. So is hospice care properly described as where palliative care becomes the main objective to the exclusion of other treatments?
So in a sense, yes. So hospice care is when we've stopped aggressive life-prolonging treatment and we're starting more aggressive symptom treatment to treat quality of life. And this is leading to the end of life because the prognosis to qualify for hospice is 6 months or less. And so it's really like a pure palliative approach, but we try not to interchange those terms too much because it gets confusing with, palliative care is from diagnosis on. It's not just for the last 6 months of life. And then hospice care is specialized for specifically end-of-life care at the last 6 months. Although many patients have actually outlived that prognosis under hospice care because they are also focusing on that quality of life. But when someone is under hospice care, then at that time they cannot be pursuing like life-prolonging treatment. Usually, there can be a few exceptions to that rule. That can be an aside, but yes, okay. Usually no life-prolonging care.
Okay, and it kind of on the line of definition. So how does palliative care differ from integrative care then?
So integrative care.
Yeah.
Sure. Yeah, integrative care is, like a holistic approach, but that could be anything. Like you can get integrative care for your primary care. Palliative care specializes with serious illness, where integrative care, I'm sure they're probably trained with serious illness to some extent, but that's kind of more of a general as like a primary care provider helping with like holistic care for your whole life. Palliative care really gets involved when there is specifically a serious illness because we're trained to help with really complex symptom management, complex decision making. And so that skilled communication, that skilled symptom management is very specific to palliative care, whereas integrative care is kind of more of a like primary care approach to all of life. So there can be a little bit of overlap because we're both seeking quality of life. We're seeking a holistic approach. But that's where, I hope that was clear, that's kind of where we differ.
Okay. And then we've got one back to the cost. So I don't know, this is a pretty big one, but like it can vary, I imagine, but what is the cost if you don't have insurance?
Yeah, I don't know if I have an answer to
Yeah.
that because
Okay.
I work in the inpatient setting. So if it was like an outpatient and someone had to pay out of pocket, I'm sure it does vary by place. So
Or service, maybe.
you would probably just need to ask and run it through insurance, or if insurance for some reason didn't cover, just ask how much it would be. Yeah.
Okay. So can the industry come up with a better term for palliative care at the beginning of a diagnosis and well prior to hospice? Symptom management comes to mind. Our first thought went to hospice when palliative was mentioned and we imagined the worst.
So, sorry, is the question, could there be a different term than palliative medicine?
Yes. Or
Yeah, because I know this has been a confusing point when palliative medicine has been brought up. Many people and providers as well think of hospice. I think what we're just trying to do is reinforce to palliate is just to provide relief. That's all it means. So it might just take time for this to be separated a bit. Oh, did you have a follow-up?
And if I could add to that just quickly, sometimes palliative care is called different things. Sometimes the term supportive care is used. Sometimes palliative services are embedded in like pain clinics or pain and palliative or supportive pain management and supportive care. So sometimes they call it different, different things. So just wanted to add that as well.
Yeah, no, that's great.
Okay, here's another. So how easy is it to appoint a decision maker when dealing with a same-sex couple that maybe is not married, when one's parent is not the person of choice?
So anyone can decide for themselves who it is. You do not have to even be related to them.
Okay.
We just need that documented because every state legally has a hierarchy. So if there is no documentation, we have to go by that hierarchy legally. You can look it up, but usually if it's, it could be spouse, or if there's no spouse, parent, or children. Anyways, it just depends on, everyone's situation is different. So that's why I really recommend if you do anything, if you do nothing else, appoint a healthcare agent, especially if it wouldn't be someone who would be on that hierarchy. Because as long as we have it documented, totally fine. It can be a verbal thing. Whenever I see patients in the hospital, I ask them, who would you want to make decisions, if they can tell me that? And I document it.
Okay.
And even if in that situation, if something happened to that person where they couldn't make decisions, I can say, well, they gave me a verbal that this person is making decisions for them. But sometimes someone comes in and they can't tell us that. So having it documented is the most important, and it can be literally anyone. They don't have to be related to you.
Okay. And on that note, who enforces the medical directive? So is what's written enforced if a loved one disagrees? Should you give those documents to hospital care team or
Yes.
or wait for a family health care agent to bring in when you can't make the decisions for yourself?
So I would always recommend bringing in your healthcare documents, especially if you are at a certain institution, maybe like that's associated with a clinic, and so that all the documents are in the same place. It's just so helpful to at least submit them one time. So if you're in the hospital, you're in the clinic, everything's just right there. Your healthcare agent, we would hope, would make decisions based off that document. Technically, someone could change what they decide, and that's partially because the document's filled out at one point in time. Sometimes we've had people come in and say, no, they've changed their mind. And so while this is a guide, it's not necessarily like legally binding. And so what we have to go off of is if the person can't make decisions for themselves, we try to use the healthcare, like I always bring it up and say, hey, I see that your loved one said they do not want or they do want X, Y, or Z to inform the conversation. But at the end of the day, whoever is the healthcare agent will make the decisions. If we think it's an ethical dilemma, though, there are things like ethics consults and things that we have brought up when we worry that it may not align with what the person would want. So we do, even on our own, try to advocate for that person, but make sure whoever you delegate really aligns with what you would want. That's very important. The other thing I'll say when it comes to documents, so an advance directive is like a guide, and it's really the main qualification it needs are 2 witnesses. It doesn't need a lawyer, doesn't need a notary. So we bring that in to help guide us. But for an actual order, there's a separate document called a MOLST or a POLST, which is a physician order for life-sustaining treatment. So if you want something that is more binding, this document is an actual physician or advanced provider's order that literally checks off boxes that looks at like life support, artificial nutrition, dialysis. That document is followed by people like EMS. So if something happens to you at home and you have said, I do not want aggressive things like being put on life support, and you have that document at home, EMS will abide by it. But if you don't have that and you just have an advance directive, EMS cannot abide by just an advance directive. They need this POLST or MOLST form. If you have more questions about that, I would just say talk to your provider about filling out a POLST or a MOLST. Because that one is an actual physician's order.
How do you spell a
P-O-L-S-T.
Okay.
In Maryland, we call it a MOLST, so it's M-O-L-S-T, Maryland Order for Life-Sustaining Treatment.
Okay. Great. We have another question from a viewer at home. So I felt like my partner was being over-medicated by a palliative care doctor when we were in the ICU. Our regular palliative care doctor, our regular palliative doctor, we told, was in clinic only. Who is in control of pain medicine, patient or palliative care doctor?
So it sounds like they had a pain specialist in the hospital or a palliative?
Yeah, maybe, right. Maybe their palliative care doctor.
Was outpatient.
Right.
Yeah, so we come across, I mean, every institution's different. Some places only have like a pain team where they're not, palliative, we're more holistic. We include the skilled communication, the emotional support. There are some places that have just literally pain teams, and they do more like infusion-based things and different procedures as well. So whether or not this was an inpatient palliative team or a pain team, you know, if I'm seeing a patient in the hospital, our team really tries to coordinate with the outpatient palliative care team because we can look at documents online, but it's helpful to know what regimen they were on. When someone's in the intensive care unit, yeah, that can get tricky because they're very, very sick, and then adding on different medications could cause like more sedation effect. If there's ever a concern about someone's care though, like you should be able to reach out to your outpatient provider to reach out to the inpatient as well. But just, you know, just advocating, speaking to the primary team. So whoever, if someone's in the intensive care unit, they'll have an intensivist, you know, kind of running the show. And so even just speaking to them about your concerns, because we want to do everything to align with someone's goals. And so if they feel like they are, you know, there's too much medicine on board, they would not want this, we want to honor that. And so just speaking up to the team, and hopefully the palliative team or whoever that team was would be receptive to, you know, making changes to that. But in the hospital setting, usually the outpatient provider defers to the inpatient provider, but there should be a level of collaboration where we're talking about, hey, this is my patient on the outpatient setting, this is what we've tried, this has been helpful, this hasn't been helpful. So then that helps guide us while we're in the hospital helping patients.
Okay. So speak up, I guess. Communication. I have stage 4 advanced cancer. I'm taking targeted therapy. However, the side effects I don't feel the side effects, but I have them so bad that I hospitalized and almost died. Can palliative care still be able to help me if I don't? Basically, the question is, can palliative care help me if I can't show my symptoms?
So yes, I guess, yeah. I guess it depends on what those symptoms are. So we can help with any symptoms. And, you know, it would just depend on what is showing with the symptoms. If they're not felt, but they lead to complications in the hospital, then there's probably something underlying going on.
Yeah.
And part of that would probably be us coordinating with the oncology team too, to figure out, because, you know, symptom management, we want to get to the bottom of the symptom and see, is it a complication that does need more medical care, or is it a simple, like you're short of breath, and maybe there's a viral illness on top of it or something like that. So we want to make sure we're coordinating with them, and if someone's symptoms are leading them to be hospitalized and are that serious, we want to make sure we're getting to the root of things. So we want to coordinate with their primary team too, but then be on another set of eyes to look at those symptoms to help them feel better. So hopefully that answered that question.
Okay.
But, yeah.
Back to the advanced directive. Sorry, we're hopping around a little bit, but this is also from a viewer at home. I get stuck on advanced directives forms, on the advanced directives form. What professional can I ask for help when completing it?
Palliative medicine,
Okay.
yes.
That's an easy one.
That's
All right.
what we do, and
Okay.
and like some of the forms can be really like legal, and the wording can be kind of, you know, hard to understand. So the Prepare for Your Care and the 5 Wishes really simplifies those. So if you're maybe doing just like a state regular mandated advanced directive and it's a little hard to follow, I would recommend maybe going to like prepareforyourcare.org and just seeing if the way it words it is a little bit simpler, but always do it with a healthcare provider, and I would recommend doing it with a palliative care provider, yeah.
Okay. How can I maximize palliative care when I am lucky enough to have very mild symptoms relating to fingernail breakage and minor cuts on my hands? So maybe what are some of the other?
Yeah. So even if your symptoms are mild or there's mild disease, but it's still a serious illness, getting us on board early never hurts. The nice thing about that is we can help with continuity of care. So maybe your symptom is super mild, and maybe we can give a few recommendations, but overall you're doing okay, tolerating the treatment okay. I think just having that extra support can still be helpful. You're still seeing many specialists. We still want to walk you through how's it going with your family or with those closest to you. What are other things in the community that could be helpful for you? And then especially if your disease did progress, then we would be that continuity to keep walking with you through it. And if symptoms change over time, we can keep help adjusting things. So it might even start with just less frequent visits, which is great. But then it can just keep being dynamic and change over time. So it never hurts to have us involved. Yeah.
Okay. Yeah. And that's why I know when I'm doing palliative care as well, I kind of join late in the process, but it's kind of we have an ongoing check-in appointment that we kind of have set up. So there may not be anything going on, but I'll at least call and kind of check in what's happening. So that's been helpful.
Great.
So at least I know I have kind of a backup in case there is something that comes up.
Yes, exactly.
And then looks like we have one last question. Do all states honor MOLST or PULST forms?
Yes, they should. Every state might be different with what they call it. Most of the states call it a PULSE form. Maryland is just different. I'm not sure why they call it MOLST. But I would just look up wherever state you come from. Look up the PULST and what does your state have. It might just be a PULSE, but they could name it something else, just to make sure that. But every state should have a version of it that they do honor, but I would just always verify it because it can be state by state dependent how they do it.
Okay. Oh, and here's a
And
question. Daniel, what has your palliative care experience been? So with me, I started a little bit late in the process. I found out through the Hope Summit and really our virtual weekly meetups when they talked about it. So if anybody's not doing the virtual meetup, I think for me, that's been like a lifeline for me to dial into that weekly call or just have the availability to do that. And on there, there's so many resources, and one of the talks one time, Christy brings in an expert, was on palliative care. So, I was probably almost a year into treatment before I even sought out my palliative care doctor. And at the time, I was thinking, do I really qualify? I was kind of on one of those persons with maybe less mild physical symptoms, but it's really been a change for me because I know my oncologist, he's focused on kicking the cancer piece of it, but he didn't always have time, make up a mind. He doesn't have time to, for all the survivorship piece and the quality of my life too. So it's been a lifesaver for me, and if you haven't talked to a palliative care, I would suggest you do.
Awesome.
Thanks, Kate.
Yes,
That's
you.
great.
Yeah.
This has indeed been fantastic. And just to clarify, the PULST physician order for life-sustaining treatment or MOLST, medical order for life-sustaining treatment. The acronyms can vary by MOST or POST or MOLST or PULST. So whatever your state has, you can look those up and learn more about them. Is it me, or are there some underlying themes, right? I know we have a savvy group, and I know you're picking up on it. Self-advocacy, communicating with your physician, being proactive, getting palliative care on board, and speaking up and letting your team know what you need. And it's hard to challenge a medical team that you love and that you trust. But we are our own best advocates, right? Absolutely. So Daniel commented on our weekly meetups, and I don't know that a week passes that we don't discuss palliative care. And I feel certain that I can say unanimously, our community, members of our longevity family that have been seen or are being seen by palliative care, they all sing the praises of the palliative care team and having those experts in their corners. Wouldn't you love to have someone like Kate on your team advocating for you? That's incredible. Let's thank you for the round of applause. Thank you, Kate, and Daniel did a fantastic job as well. Thank you both.